Welcome to Stigma Shakers podcast. I am your host, Ali Hensley, author, speaker, and stigma shaker of the best kind. This podcast is all about shaking and breaking up taboo into digestible chunks, which we like to call our social smoothie. In this podcast, I will ask the difficult questions that can be hard to digest because everyone deserves a little balance in their mental health diet. And let's face it, folks, the only thing normal in this world is different. So my question to you, can we make truth the next biggest trend? Sarah Graham is an award-winning freelance health journalist and founder of the Hysterical Women blog, specialising in health, gender and feminism. She has written extensively on these subjects for the newspaper, Refinery 21, the Telegraph, Grazia, Guardian, the BMJ and many others. She was a finalist in the 2021 Medical Journalists Association Awards. So this is the season finale of Stigma Shakers podcast, and I am super excited about this one. As women speak out about their experiences of gaslighting and misdiagnosis, my guest today, health journalist Sarah Graham, and author of Rebel Bodies, A Guide to the Gender Health Gap Revolution, intelligently offers an empowering manifesto for change in women's healthcare. This is the book that I believe deserves to be on every classroom shelf. So thank you so much, Sarah, for joining us today. I've been looking forward to this ever since we first Zoomed a couple of months ago. How are you?
Yeah, very well, thank you. Thank you for having me.
It's such a topic close to my heart, obviously, as a women's health advocate, specifically in my sphere of MRKH diagnosis, which I've talked about and peppered throughout the episodes of this podcast. But I think understanding and having read your book twice, it's such a conversation that really needs to be had. But the way that you wrote your book and have written your book is so intelligent in terms of empathy, relatability, and the sheer length of research you've done. Like, your statistics are insane. Like, the facts are quite terrifying. What was your motivation of becoming a health journalist, and of course then the author of this incredible book?
So I always wanted to be a journalist since I was about 13 probably. I loved writing, so that was what I did. I did my degree and then I did a master's in newspaper journalism, and I was interested in women's issues in the kind of broadest possible sense, really. I was interested in feminism and all the sort of things that were going on in sort of the early 2010s around the feminist movement. And so when I graduated, I got a job on an online feminist magazine. And that really was kind of where the whole journey started, really, because I was writing about all of these issues. But the ones that I found myself sort of most drawn to were things around mental health, reproductive health, reproductive rights. I was doing a lot about kind of abortion rights and that sort of thing. And when I went freelance about a year later, those were sort of the areas that I decided to really focus in on. And yeah, so over kind of the following few years, I was writing more and more about these issues. And actually, it was an article that I wrote for Stylist in 2018 about endometriosis that really kind of kick-started this whole exploration of the gender health gap. Because I interviewed a woman who had endometriosis, and she'd had symptoms since she was 13 years old when her period started. But it had taken her 10 years to get a diagnosis. And as a result of the delay in that diagnosis, she had permanent damage to her bladder and her bowel, which meant that she was now living with sort of long-term, lifelong bladder and bowel complications. And I was really struck by some of the things that she said, that her mother had endometriosis, and she and her mother had a really difficult time. They were back and forth to the doctors. She's actually in the book, and I spoke to her mother about this experience of being told that she was just copying her mother, or her mother had put this idea in her head, and that actually there was nothing wrong with her, and all girls have difficult periods. And that story in particular really kind of got me interested in these issues. And then I started noticing more and more that, all of the women that I was interviewing were saying similar kinds of things about feeling dismissed, that they weren't listened to, they weren't really heard by their doctors, they were not taken seriously. And so it was that frustration really that got me digging into it more, that inspired me to start my blog, Hysterical Women, which ultimately was what the book came out of. It sort of evolved into that.
So in terms of gender health, and I remember when we first had a phone call on Zoom, we were talking about women's health, and you said, but it's not just about what happens below the belt, and that can also be like a bit of a misconception. So can you explain, as I guess succinctly as possible given the time that we have, about what is gender health and what are the issues around the gendered health gap that you've really found fascinating to explore?
Yeah, absolutely. And I think, like you say, often it is issues like endometriosis that people think of. That was the issue that kind of first got me looking at some of the challenges in women's health. But what I've been really struck by is actually it comes into every single aspect of healthcare. So when you look at things like the fact that, research shows women are kept waiting longer in A&E than men, women are more likely to be misdiagnosed while they're having a heart attack, and as a result are more likely to die from a heart attack than men. It comes into things like mental health, when you talk about all these kind of stereotypes and attitudes that women with mental health issues are drama queens, or they're just attention seeking, they're being manipulative. These tropes come up in so many different areas of health. And that is something that I really wanted to highlight through the book, that, it's not just about the gynae stuff, the wombs and vaginas, although, that is a very big part of it. But actually it's a much bigger problem.
When I read about the book, as you just said, in terms of women and the disparity of, say, heart attacks with men, and then, of course, the tragedy of that, are there, in terms of for our listeners to really relate to, specific, I guess, diagnosis or a particular health matter that are really different between male and female healthcare? You just listed heart attacks for one of them. What others do you think are being so obviously missed in that way?
I think heart attacks are the most obvious in terms of, something that you think of as being fairly gender neutral, but where actually, they're not necessarily treated in equal senses. There are quite a few, though, where, you look at things like asthma, for example, or epilepsy, where actually we know that a lot of women, they have their symptoms triggered by their periods, for example, and there is so much less known about these issues. I think another one that I was really struck by in the book was issues around kind of, gastro pain. So there was one woman who went into A&E and she had pancreatitis. And, she spoke about the fact that she was a woman in a large body, and all the doctors seemed to be able to see was the fact that she was fat. So she was repeatedly sent away and told, you just need to lose weight, and that will solve all of your problems. And actually, the more weight she lost, the more pain she was in.
No, I really remember that, because, as you say, there's almost a reluctance, and people are, I find, incredibly polite with their health, and I think a lot of people don't want to come across as being a nuisance or a burden or a hypochondriac. And when you talked about in the book about, for instance, one of those was the stigma against weight when it comes to health, and a fact that I did pull out was 68% of women delayed healthcare due to the fear that their BMI would be used falsely against treatment. And that's just one example where people are unlikely to want to go to the doctors even, let alone what happens potentially when they get into the treatment room.
Yeah, absolutely. And I think there are so many examples like that where, past experiences of stigma or of being misdiagnosed or of being disbelieved really has a huge impact on the trust that patients have with their doctors. And that is so potentially harmful because it does mean, that relationship breaks down and patients delay going back to their doctors, which means that things could then be missed, things could be diagnosed late. And with the example of something like cancer, that can have a really serious consequence. We know that early diagnosis saves lives, and things being caught late worsens the prognosis that people have. There's a huge issue with trust being lost, and we see that particularly with Black and other ethnic minority groups, with fat patients, with LGBTQ patients, for example, where they put off going to see the doctor because they fear that they won't be taken seriously, they fear that they'll be stigmatized or misjudged in some way, and that has huge long-term implications for people's health.
Absolutely, completely. And when you were talking just about early diagnosis when it comes to cancer, your chapter, which was brilliant about the war against cancer, I often think about in terms of the educational aspect. For us as people also to be able to advocate, we need to have knowledge. And one of the statistics, and I love a good stat, was that 44% of women couldn't identify the vagina and 60% didn't know the vulva. So how can we even, for instance, in this particular area of the body or type of cancer, how can we spot it, prevent it, or intervene if we don't know our anatomy? So where does that lie? Where does the knowledge around our bodies kind of lie? At what point in our lives should we be tuning up to that? Whose responsibility is that?
I think it is everyone's responsibility. I think we as a society need to get better at talking about vaginas and vulvas and wombs and all of these, things that are still really taboo, but actually they are essential. And as you know, I have a toddler. One of the conversations that my husband and I had when we were pregnant was around, and I think it is particularly important for girls. I have a boy, but actually using the correct anatomical language, like vulva, vagina, penis, so that actually they know what those parts of their body are. If something goes wrong, they can accurately describe, where the pain is, where the itch is, whatever it is. So I think, parents have some responsibility, like right from day one, really, when you're changing nappies. I think schools also have a really big responsibility. I think, certainly my memories of sex education were pretty poor. Like I don't remember learning about my anatomy. I don't remember really learning about anything other than sort of the mechanics of how to get pregnant, how not to get pregnant.
I remember a banana in terms of putting on a condom. And it's so interesting. I feel like I only was in class one day when we covered reproductive health, which royally screwed me up because having been born without a uterus and an underdeveloped vaginal canal, then when I found these things out, like not after school, literally 3 p.m. after school, but when I finished high school education, or secondary education I should say, that completely threw me in terms of being outcast, wrong, what type of woman am I? What type of woman am I if motherhood isn't part of my plan? And I think that's even like the larger scope, the real lateral look at education as well. And I think the word gap is so prevalent across all the topics that you cover in the book. And I particularly loved reading about the gender pain gap. Talk to us a little bit about that.
Yeah, so I mean, the gender pain gap is really kind of the heart of it for me, because it comes into so many different aspects of health. But there is research going back 20 or 30 years looking at the fact that women's pain is taken less seriously, is treated less seriously than men's pain. So women who present in pain are less likely than men, for example, to be given painkillers. They're more likely to be given anti-anxiety medication. So there is this real, very deep-rooted problem of women's pain not being taken seriously, or of it being normalised, which I suppose, in some ways is kind of the opposite, but there's this kind of attitude that, as a woman, you're supposed to be in pain. It's normal to be in pain. But actually, it's not really that bad. You just have to suck it up. You just have to get on with it. Whereas I think, if a man says, I'm in a lot of pain, that is taken much more seriously. They're much more likely to be prescribed heavy-duty painkillers than a woman.
Do you think this comes into the effect of, you sort of open the book by talking about the hysteria and its links to Greek mythology and how Sigmund Freud deciphered it. And I found that really eye-opening. And yet I still feel like that is still really those outdated, I guess, assumptions or theories. I feel that there's still an undertone of that, even throughout, 2023, as you say, about mental health and, even motherhood, like going through pregnancy. Is that having to cop pregnancy in terms of the difficult issues around pregnancy? It's almost like, well, that's a byproduct because you're growing a child, so deal with it.
Yeah, absolutely. I mean, I think this is something that you see kind of throughout our reproductive lives, in a sense, this idea that, you are assigned female at birth, or you're somebody who's born with a womb, and this is just an inevitable part of life that you have to just put up with. So you see it with period pains or heavy periods, you see it with pregnancy complications, things like hyperemesis gravidarum, which is really severe morning sickness, is dismissed as, oh, it's a sign that you have a healthy pregnancy and just eat some ginger biscuits. But actually, it's really debilitating and actually quite dangerous, both for the mother and the baby. You see it again with postnatal issues. Like, one of the women I interviewed spoke about having really severe postnatal incontinence, like wetting herself in mother care, really awful experiences. And that just being sort of written off as the price you pay for having a baby. And I think the same all the way through to menopause, this idea over and over again that this is just what women have to put up with. And your mother put up with it, and your grandmother put up with it, and so should you.
Right. There was another scary stat, let's say, about menopause. And I think the topic around menopause is just starting to sort of creep out the woodwork a little bit. And there is a fact, which was 14 million working days per year are lost due to menopause. So the stigmas around gendered health is actually having a massive impact and knock on to the economy, such as when 8.2 million cost the UK economy just on endometriosis. There is an economic downfall with doing this. So it's almost becoming incredibly counterproductive by not having these conversations, even on a governmental, political level, would you say?
Yeah, absolutely. I mean, I think that's one of the real frustrations that I feel about, the lack of research, the lack of services for these kinds of conditions, is that, when you look at the economic impact they're having, they are excluding women from their workplaces. With something like menopause, for example, you're taking women who are in really senior positions potentially. They're at the top of their game, they're very experienced, they might have 30 years of experience, and suddenly they're reducing their hours, or they're not going for promotions, or they're having all of these mysterious days off because they can't cope with the symptoms and they can't get the support they need to be able to cope with those symptoms. I think it's incredibly short-sighted that we're not doing more in terms of early intervention, educating both patients and doctors about the issues, and also as employers looking at ways of, ensuring that the support is there in workplaces as well.
Yes, and I remembered a time as you were talking about that, I wasn't a high flyer, but I was working in a good job in corporate. And at the time I was looking at doing egg retrieval, egg freezing, if I was going to eventually look at the IVF process. And I asked my boss if he could quietly sort of come into my office and close the door, because I had something very personal to tell him, which of course it was personal, but even the conversation was really odd, because it was very sort of hush hush, almost apologetic, almost feeling a little bit guilty, inadequate. And then him opening up about his struggles that he was going through with IVF, and then 2 doors down someone else was also going through the IVF struggle, and which we know is 1 in 8 people, 1 in 8 couples. So it was really interesting when you said that about the workplace. It's such a big factor for people because, yeah, we spend so much time there, and yet it is obviously impacting on a huge economic level with money, which the government will not like. I think a really big, profound part of your work, Sarah, and it's so relevant, is health around the LGBTI and those who are transgender, and how they really do have so many obstacles, which I know is so generic in terms of what we know, but you paid focus to that quite heavily in your book. What are some of the key issues that transgender people are truly facing, and why?
It was really important for me to include the whole spectrum of the trans community in the book, really. So trans men, trans women, and non-binary people, because I think in lots of different ways they're facing challenges within the healthcare system that are very similar to the challenges that cis women are facing. At the same time, they're also facing lots of very different challenges, that are, things that I will never have to go through. So I think one of the things that I was really struck by, that I learned about a couple of years ago, was this phenomenon called trans broken arm syndrome, which is, a trans person might go to their GP, might go to the hospital with a really normal, routine health issue. They might have tonsillitis, they might have a broken arm, they might have an infected cut on their hand. And doctors, because they're trans, seem to have this almost kind of a panic, I think, that, oh God, I don't know what to do because this is a trans person, I've never treated a trans person before. And so they they experience things like either being told it's because you're trans, or it's because of your hormone treatment and I need to refer you back to your gender specialist, or they're told, oh, I can't prescribe you this because I don't know how it will interact with your hormone treatment, etc. Things that actually, when you think about them logically, one of the trans men that I interviewed was told he couldn't be prescribed antibiotics because he was on testosterone. And he was like, well, a cis guy has the similar levels of testosterone naturally and would just be prescribed antibiotics without a second thought. But there just seems to be this kind of block. And I think a lot of it does come from ignorance and from fear, where doctors are scared of getting it wrong, of doing the wrong thing, and they just think, oh, it's just easier if I just refer you back to your gender specialist. But actually, a gender specialist is not there to treat tonsillitis or a broken arm.
Right.
That is something that general doctors should be able to deal with themselves. So that is a really big thing. And I think the other thing where there's a lot of crossover with, a lot of the issues that I talk about cis women facing is to do with just a kind of basic bodily autonomy, being trusted to know who they are, what they want to do with their body, to be able to make those informed choices. I think that is something that comes up time and time again. And I don't have the space or the expertise within the book to go into, the sort of wider issues with transition-related healthcare. But I think even just within the more general healthcare sphere, there are huge kind of barriers facing trans communities.
And as you say, there are many podcasts and many more books to follow on this topic alone. But as you said, I went to a conference a few years ago in relation to, for me, MRKH, and this, probably about 6 or 7 years ago. And the same topic as we've just been discussing now was really relevant in context to this then, and that was a complete fear factor around not wanting to get it wrong and the liability potentially of getting it wrong. And as you say, what that then just puts a whole bunch of shame and fear in the patient themselves, and before you know it, as you say, that gap just completely gets bigger and broadens. And likewise with the LGBTI, and I feel like I'm just skipping through this, it's not at all, there's just so much I want to cover. There was a really incredible fact and statistic that you put in the book that drew my eye, which was that Black women are 4 more times likely to die at childbirth than white women. And so then we come down to a completely sort of sub-gender issue in that way. What's some of the findings, I guess, or the key things that you were drawing out in that way?
Yeah, absolutely. So I think, as we've discussed with the LGBTQ community, there are so many different factors besides gender that come into the gender health gap. So anybody living with multiple disadvantages, multiple forms of discrimination, is going to face those kind of multiple barriers. I think with things like racial disparities in maternal mortality, that, yeah, as you say, there have been some really shocking statistics in the last few years showing the experiences that Black women in particular have. Some of the women that I spoke to, describe very similar things to what we've already spoken about, that, feeling that they weren't listened, they weren't believed when they were in pain. I think, though, that one of the really important differences for Black women is that there were all these racial stereotypes that came into this, as well as the stereotypes about women. So, for example, there was a really shocking study in America in 2016 which looked at the fact that medical students and postgraduate trainees, something like 50% of them held at least one false racist belief about Black patients. And it was things like, Black people feel less pain, Black people have thicker skin. And when you look then at the racial disparities in maternal mortality, the fact that Black women are more likely to die, and they're also more likely to suffer really life-changing injuries in childbirth as well. I think those racist beliefs about pain thresholds really do become very, very significant when it comes to things like childbirth, because if you believe that a Black woman can withstand more pain than a white woman, then you can understand why they might be less likely to give less pain relief or to withhold that pain relief. And actually that is just not true.
That reminds me, when you were saying that, in my early days of advocacy in Australia, when I was really sort of trying to understand diversity and difference, not just within Australia, but looking at the broader perspective, or people within Australia with varying cultural beliefs. And there's been a few thrown around about MRKH, one of which was a male doctor, and I respect what he was saying, but I found it incredibly confronting that a banana leaf treatment applied correctly can grow a person's uterus. And I do respect that is a belief system, but I also think it was incredibly terrifying, because this was the information that was going out with not very much evidence, if in fact no evidence. I know that some people within the world have been told that if they stand in direct sunlight, their MRKH diagnosis will also be eradicated. And so I'm always really conscious and mindful of cultural beliefs also, but I don't have an answer, but how to sort of open up that conversation when it comes to even looking at other pockets of the world that are going to have a disparity between what we know and what they know, and how we can, so many bridges to gap, Sarah, so many bridges to gap. To flip it slightly on its head, a little bit with stigma shakers, of course, we just talked about the racial disparity amongst women, but across your research and time as a journalist and writer, is there a difference in care, say, between Black men and white men, or do you think this is female specific?
Yeah, I mean, I think it is such a complex issue that I don't think, I certainly think that racism across medicine is a problem, and I don't think at all that it's exclusive to women. I think in lots of ways there are probably examples of times where a black man might have worse treatment, for example, than a white woman, and it's a really complex picture. I don't think we can kind of talk about sexism without also talking about race or other forms of discrimination. So yeah, I absolutely think, it's not saying that all men have a really easy time of healthcare, because they absolutely don't. Black men, for example, are massively overdiagnosed with schizophrenia and some of these really stigmatizing mental health diagnoses. And so I think, absolutely, it's not been a particular focus of my work, just purely because my work has focused on women. But yeah, it's absolutely not to say that black men or disabled men or trans men or gay men have an easy time of it, because they absolutely don't.
And well, there is that, I don't know whether it's stereotypical of me to say, but we do know that, for men who are obviously listening as well, they can be notorious when it comes to not necessarily sharing their health concerns. Not everybody is leading from the front when it comes to advocating for their bodies and their health. And as you say, there's a fear around opening up around mental health, and this is just the tip of a huge iceberg. But I'm really grateful for you answering that, because I think it was just really, it's tangled, interwoven issue that we continue to face. When I read the book, and being a health advocate for my charity and my work, is I have made it a really important objective of mine to work with healthcare professionals across multiple countries who are best practice at what they do. How has healthcare providers, or the medical institutions, reacted to your book? Because I don't want to say there's negativity, because there's an incredible amount of positivity, but do they feel blamed or targeted at all?
I don't think so. I mean, certainly, it probably, slightly comes down to a question of which of them have read my book, and probably the ones who have read the book are the ones who are a bit more open and a bit more receptive to begin with. But no, generally speaking, I don't think there has been that kind of negativity. I think one of the things I was very careful to do was to try and make it a very nuanced conversation that didn't pit healthcare professionals and patients against each other. So I wanted to present experiences on both sides of that fence, to be able to show, these are some of the challenges that doctors are facing within the NHS, within the medical system, within the medical knowledge that we currently have. So no, I think certainly from the conversations I've had with healthcare providers so far, they have appreciated that level of nuance. They've appreciated me presenting their side of the story, so to speak, and making it clear that there are challenges, to do with the lack of research, to do with the lack of training and education that they have. And there are some really fantastic healthcare providers, many of whom I interviewed for the book, who are out there trying to improve things, who are, paying for extra specialist training out of their own money, doing it in their own time, who are engaging with patients on social media, for example, who are really trying to sort of push the, sort of equality and diversity agenda, whether that's through racial equality task forces or, working on the women's health strategy. So I think there is a lot of engagement within the medical community. There's also, inevitably corners of that where people are perhaps a bit more reluctant and dragging their feet. But I think on the whole, people understand the issues and are wanting to do something about it.
And it's incremental, change after all. And what you said about the healthcare providers that you've spoken to and wrote about are clearly also wanting to see some change as well. And I remember speaking to various activists along my time working within the charity women's health sort of sector, if you like, and I think there's a way to proactively get those conversations started. And I think once you're in the door, or once you're in the inbox, and you find the right person to sort of partner up, I think then you've got a chance at change. Like the amount of times I had to email hospitals across Australia, and 90%, because of their workload, and I was just, this fluffy blonde, I'm being a bit sort of derogatory about myself, but just who is this girl talking about wanting to do MRKH peer support? Because are we going to sit around and braid each other's hair and wipe away each other's tears? And I was trying to emphasize that peer support is actually part, or hopefully part of, a treatment plan, and be a necessity, and not just be seen as this, oh, that'll be nice, we'll just let them go and do that. But it was getting to the right people to really filter down. So if you can get your foot in the door and find the right people, and as you say, bridge the gap has always been something that I've always talked about when it comes to raising awareness and making change.
Absolutely. And that was something else that I really wanted to do with Rebel Bodies, was, to show people that there are lots of different ways to do advocacy, there are lots of different ways to be an activist, and they don't all necessarily have to involve, going on marches or having meetings with MPs. There are lots of ways that people can get involved, and there are lots of existing campaigns, lots of existing support groups that people can link in with and work together with. It doesn't have to be you sitting at home on your own feeling helpless because I'm just one person and what can I do to change all of this. There are lots of different ways to get involved.
And I think when you said in the book about death means we believe you now, and I often think about how many people go to the doctors and they come home and they know something is wrong. I mean, obviously death is a terrifying, extreme example of that, but what can people do if they know something's wrong and they truly are not necessarily feeling like they're being heard? Because it's quite scary to stand up to an expert.
Yeah, absolutely. And, I acknowledge in the book that is a really scary thing to do at a time when you're feeling especially vulnerable because you're not well. I think it's not always going to be possible to do that in the moment. I think if you can take somebody with you who, either makes you feel more confident so that you feel more able to speak up, but, equally it might be that you take your mum or your partner or your best friend, and actually they can speak up on your behalf and say, no, I don't think you're listening. I don't think you're taking my friend seriously. That can be really powerful. I think having research or, going along armed with some knowledge, or, a symptom diary, for example, something that gives your doctor something to work with, can be really helpful. Equally, I think if somebody just really isn't listening and you're not getting anywhere, knowing that it's okay to ask for a second opinion, you're allowed to do that. You're allowed to make a complaint. And I think sometimes that can be helpful because, otherwise doctors don't necessarily get that feedback. So there are lots and lots of tips that I include throughout the book about things that you can try. Ways that you can advocate for yourself better. And as I say, they're not all guaranteed to work. It will depend on you and your doctor and lots of other factors. But there are things you can do, and there are mechanisms in place for you to make complaints if you need to.
You've inspired me, Sarah. You've inspired me. When I was about 6 months ago, I always get letters sent about having a cervical smear. And technically, without a cervix, there's nothing to, there's nothing to scrape. There's no smear test. And I did go, and I was really sort of gearing myself up for going, because I haven't had like anything investigatory there for 22 years. But when I said about MRKH, and I had some research with me that says that whilst you don't necessarily need to have the standard smear tests advised by the NHS, you are encouraged to have a further test every 3 years around the vaginal vault and any cancerous cells. And they did say, we'll go and ask somebody, and they didn't get back to me. And then next time came around and they said, we'll ask someone, and they said, you're not applicable. And I thought I could make a really big fuss out of this if I wanted to. But I just thought, oh, well, if they said that I'm not applicable, my health isn't applicable. And now I will probably go and have a further conversation about it, because even me, who does this for a living, I felt very I felt very sort of null and void in that moment. And I think it's worth
it's one of those things where it's really easy for me to sit here and say it. I find it really hard when it's me and my health and it's the professional sat in front of me. I totally acknowledge that it's not easy. It's not easy at all. And sometimes, particularly in the moment where you're on the spot and you just feel really like, oh, okay, fine, I'm not going to make a fuss. It's so much easier to just walk away and go, you know what, it's not worth it. And we do have to choose our battles to some extent. But equally, I think if it's something that you're concerned about and it's something that you feel like, actually, I would like to have this checked out, I would like the reassurance that everything's fine, then, it is worth pushing.
We could talk for ages. We really could talk for ages, Sarah. But I did want to just sort of conclusively wrap this up, because I think that's just a really lovely message for people to sort of end on, about picking your battles, but also standing up for your health. Here at the Stigma Shakers podcast, our aim is to shake up and blend unique smoothies for our listeners to digest around the topics of stigma and taboo. Now that we've come to the end of our incredible discussion, what social ingredients would you like to have in your social smoothie to improve people's outlook, mental health and judgments?
Ooh, that's a tricky one. What ingredients? I suppose the three things that I always come back to in the book are research, education, and the sort of cultural conversation, really. So we need better research. We need to understand what is going on with our own bodies, with other people's bodies, with our patients' bodies. We need research that takes into account differences, and not just the obvious differences like race or disability or sexuality, but, even differences between cis women. So that, I think, is a really important one. Education and training, obviously we've spoken about this loads, but public education, awareness about our bodies and our anatomy, but also the education and awareness for doctors, for that research that I spoke about to then filter down, and for doctors to understand more about women's bodies and how they work, and differences between men and women, and conditions that mostly affect women. And I think, the really important kind of final thing is just, as you say, shaking up some of the stigmas, some of the stereotypes, some of the attitudes, some of the sexism and racism and transphobia that still exists in society, and really kind of turning those on their heads and looking at the way that we think about health, the way that we talk about these issues, the way that doctors make clinical judgments, and really getting them to sort of reflect on those.
That sounds incredibly nutritious and really chunky and yummy. Does your smoothie have a name? What could we call it?
Oh, let's call it the Rebel.
I was just looking at the cover of your book. I was like, it has to have Rebel in it. It is called the Rebel. Very good for your diet.
Rebel smoothie.
Oh, the Rebel smoothie. I have that every day. If there could be a headline on today's news about the work that you do to get out there and broadcast to everybody, what would that headline be?
Oh, God. What would it be? I think one of the things that I say a lot, because I remember when the book first came out, somebody was talking about the book, and they described the gender health gap revolution as your revolution, as in that it was like my revolution. And I remember being like, no, this is like, I'm just here documenting it. I'm a journalist. This is not my revolution. So I think the headline for me would be something like, the gender revolution, the gender health gap revolution is out there. It's happening. It's already started. And anyone can get involved, and you should get involved.
Yeah, it's the gender health gap revolution is your revolution, for sure.
Yeah.
For sure. How can people find you, Sarah?
So I'm on Instagram at SarahGraham7Writer, and I'm also on Twitter or X at SarahGraham7. Whether that will still even exist by the time this podcast goes out, who knows?
Thank you so much, Sarah, for joining me today. I'm so grateful. I know you're on a massive PR push, and so your time is precious, but this is something that is so close to my heart and the heart of many, many people, and this is definitely a stigma-shaking conversation that needs to start. So thank you so much.
Thank you for having me. It's been really lovely to chat.